Welcome to the next topic of the course. Administration and care of IV therapy. The following are the purposes of the insertion of IV access to patients. Maintain and restore fluids and electrolytes in the patients who cannot maintain an adequate intake by mouth. Maintain acid-base balance, replenish blood volume. Provide an avenue for medication administration or blood transfusion. Provide parenteral nutrition. These are the following common terms that you have to be familiar with. Intravenous therapy, it is the administration of liquid substances directly into a vein through intermittent or continuous infusion. Catheter, a flexible tube made of latex, silicone, or Teflon that can be inserted into the body, creating a channel for the passage of fluid or the entry of a medical device. Medication locks, medlocks, have a needleless access cap attached to a 6 or 7-inch extension tubing placed on a newly inserted or existing peripheral intravenous catheter. Types of fluids: isotonic, hypotonic, hypertonic. The isotonic is a solution that exerts the same osmotic pressure that found in plasma. Example: 0.9% normal saline. Lactated Ringer's blood components: albumin 5%, plasma 5% dextrose and water, D5W. Hypotonic, a solution that exerts less osmotic pressure than that of blood plasma. Administration of this fluid generally causes dilution of plasma solute concentration and forces water movement into cells to re-establish intracellular and extracellular equilibrium. Cell will then expand or swell. Example: 0.45%, half-strength normal saline. 0.3%, 1/3 sodium chloride. Hypertonic, a solution that exerts a higher osmotic pressure than that of blood plasma. Administration of this fluid increases the solute concentration of plasma, drawing water out of the cells and into the extracellular compartment to restore osmotic equilibrium. Cells will shrink then. Example: 5% dextrose in normal saline, 5% dextrose in half-strength normal saline. Dextrose 10% in water. Dextrose 20% in water, saline 3% and 5%. Dextrose 5% in lactated Ringer's. Albumin 25%. Check the illustration of how the water moves in and out of the cell and how the cell reacts depending on the type of solution being administered to patient. We will discuss briefly the anatomy and physiology of the different layers of the vein to understand the characteristics of each layer and on how the IV therapy will affect them. Tunica intima is the innermost layer of the vein with smooth, elastic endothelial lining. This layer recognizes the foreign bodies, and the first layer that will be affected by the mechanical, chemical, and bacterial damage. Example: IV burns. Tunica media, this layer consists of muscle and elastic tissue, and nerve fibers for vasoconstriction and vasodilation. This layer is the part that responds to the hot or cold compress being applied. Tunica adventitia, this layer consists of connective tissue and nutrient vessels. This also provides support and protection that needs to be poked during the insertion of IV cannula. A vein that is ideal for cannulation should be bouncy, soft, refills when depressed, visible, feel round, has large lumen, well supported by surrounding structure, and should be straight. The following are the sites to be avoided in choosing the insertion site. Veins in the palm side of the wrist and the cephalic vein at the wrist level, painful, restrict movement, possible nerve damage. An arm with arteriovenous shunt or fistula. Operative arm on patient's post-mastectomy. arm with edema or impaired circulation, blood clot or infection. Orthopedic surgical patients, avoid the hands if patient will use crunches post-operatively. Veins in the lower extremities are more susceptible for complications. According to the hospital policy, intravenous fluids shall be initiated following a physician's order, which must designate the specific fluid, total 24-hour volume to be infused, and/or hourly rate of flow, and any medication additives. Intravenous infusion shall be introduced by a physician or an IV-certified nurse. A strict aseptic technique shall be used. The assigned staff nurse can have 2 attempts to insert the cannula. If he fails, a senior staff nurse in the unit should be called for help. If the senior staff failed after 2 attempts, anesthesiologist should be called. All IV solutions shall be checked for expiry date, discoloration, or particular matter before using. At the site of insertion, the nurse shall note on the dressing tape the date and time of insertion, gauge of the catheter used, and the nurse's initials and ID number. When selecting an IV site, upper extremities should always be the first area of choice, and from distal to proximal area. If blood sample is required, collection of blood shall be done immediately after catheter insertion, and before flushing the site, and attaching the IV tubing to provide accurate sample, and to avoid additional needle pricking. Blood specimen shall be labeled according to medical laboratory policy. As per hospital policy, all tubing shall be clearly labeled with date and time, and initials of the person establishing and/or changing the tubing. IV insertion site shall be changed after 72 hours or when clinically indicated, and tubing shall be changed every 96 hours to 7 days or when necessary according to the hospital infection control guidelines. For the IV solution, this shall be discarded in 24 hours after opening. IV dressing shall be changed when needed. Nurses should bear in mind that IV therapy is a dependent function. Thus, discontinuing IV fluids require doctor's order. All IV bags and/or bottles shall be labeled with white sticker, indicating the patient's name, medical record number, fluid type, and amount, flow rate, date and time, and the nurse's initials and ID number. Replacing or changing an existing catheter can be done independently by a staff nurse. In flushing of medlocks, the following should be implemented. For intermittent medication administration, flushing should be done before and after each medication administration. Omit the scheduled flushing if medication administration occurs within the scheduled flushes. In PICU and pediatric units, IV access should be maintained on KVO. However, for saline lock or medlocks, flushing should be done every 4 hours to check for patency. In adult critical and regular units, medlocks should be flushed every 8 hours. All IV fluids containing medication additives must be labeled with a red medication label with clear and complete information. Document the specific anatomical site of the vein used where the IV cannula was inserted. Do not document using unspecific site of insertion, for example right hand or left arm as IV site. The nurses should be familiar regarding the following nursing procedure to be applied in maintaining or changing medlock extension tubing. The following are the nursing procedure to be applied during administration of IV access. Wash hands with antimicrobial soap. Put on gloves. Cleanse the needleless access port vigorously with an alcohol swab for 5 to 10 seconds. Connect saline flush to needleless access port and flush the extension tubing. Remove IV site dressing and any necessary tape. Put 2x2 gauze pad under IV cannula hub. Remove existing extension tubing and access port and connect new extension tubing with needleless access port. Flush Medlic with the saline solution approximately 3 to 5 ml. Apply necessary tape and transparent dressing. Label dressing with date and time, gauze of catheter and nurse's initials and ID number. Secure extension tubing to patient. The following are the nursing responsibility to evaluate the IV insertion site. Perform site evaluation by checking for infiltration, phlebitis, and signs of infection, and equipment integrity shall include skin temperature, general condition or appearance of site, swelling or inflammation around device site, pain or tenderness around device site, unexplained fever, presence and integrity of tape and transparent dressing. Instruct the patient to avoid unnecessary motion of the arm. To notify a member of the nursing staff if the arm or site becomes swollen, painful, or if there is leakage from the site. If the patient develops complications, stop the IV infusion, inform the physician. Observe the site. Document in the multidisciplinary progress notes and complete an EOver. See the table illustrating the different IV complications with its specific nursing management to be done to patient if the specific signs and symptoms will occur. In this table, the different systemic complications was enumerated with its possible causes and nursing management to be done to patient if the specific signs and symptoms will occur. All nurses should be familiar regarding the calculation of flow rate in drops per minute and in ml per hour. The drops per minute is calculated by total volume infused multiplied by the specified drop factor, divided by total time for infusion in minutes. Try to calculate the flow rate in drops per minute by following the formula. The doctor's order is to infuse 150 ml of D5W in 1 hour, set indicates 10 drops per minute. Try to solve the example. The doctor's order is to infuse 1,200 ml of normal saline in 6 hours, set indicates 15 drops per minute. The formula for calculating the flow rate in ml per hour. Total volume in ml to be infused divided by the total time for infusion in hours. Try the example. Calculate the flow rate in ml per hour if the doctor ordered to infuse 2 liters of lactated ringers in 8 hours. Thank you for watching. Hope this course will help you to apply in your units the proper process of administration of IV access to patient, how to manage complications, and the correct way of calculating flow rate.